So, good evening, all students as well as my colleagues and seniors. So, as we know, the PG teaching is very much important, and Gurukul PATHSHALA is a program who does it from heart. So, welcome to all of you for today's episode of Gurukul PATHSHALA. Today, we are going further with the nutrition, and the nutrition is important for growth. So, whenever we are looking at the growth, we know something about nutrition. We have nutrition expert. I think growth expert, that is the most more meaningful word for the expert. And for this today's episode of growth chart interpretation, I welcome our Jhankhana Sanghavi madam, President AOP Gujarat, for her welcome address.
Thank you, Dr. Nehal. I welcome Dr. Nehal, Dr. Lata, all attendee, and today's expert speaker, Dr. Zalak Upadhyay. She is an endocrinologist, very dear and near to me. Today's topic is growth chart interpretation. See, the growth chart interpretation is not only the subject of the endocrinologist, see, accurate interpretation of the growth chart help every students and practitioner. You can identify chronic systemic illness very early. As for example, Crohn's disease. Only the symptomatology and a growth chart you can clinically put to the diagnosis of Crohn's disease. So growth chart is very, very important in day-to-day practice to identify the systemic disorders. I'm 100% sure Jhalak will enrich us in all this aspect of the growth chart. Over to Dr. Nehal, please.
Thank you. Thank you so much, madam. You rightly said how much is the importance of growth chart, not only for the students of as they are learning, it's important for the exams also, but it is important for all the consultants also in day-to-day practice. For introduction of today's expert and taking this ahead, I invite Dr. Lata. Please give the introduction of the expert and today's topic.
Thank you, ma'am. Today's topic is beyond curves. I think growth chart is one of the things that every pediatrician, every student, every faculty, everyone should learn because it is the close monitoring of the growth of a child, which is the most important thing in pediatrics. So for that, we have a great expert for today, Dr. Zalak Shah Upadhyay. She is consultant at Pediatric and adolescent endocrinologist at Endocare for Kids, Rajkot, Gujarat. She has been a key member of various bodies like ISPI, and then Academy of Pediatrics and all. And she has so many publications, and she has been reviewer for very a number of international journals. So welcome, ma'am, for today.
Thank you so much for the kind introduction, ma'am. Thank you, Jhankhana ma'am and Nehal ma'am, for the opportunity. Good evening, everyone. I'll just share the screen. Yes. Is my slide visible?
Yes.
Yes, ma'am.
Okay.
It's visible.
So, good evening, everyone. And today we learn about growth charts. So, 1.5 hour time, and this is a good amount of time to learn a lot of things on growth chart. And I have tried to cover most of the things, almost everything possible, different growth charts which we get. And it's not only about 1 or 2 growth chart, but we have many growth charts. So I'll be introducing, and I'll also introducing you to various growth charts, as well as we will learn how to plot and how to interpret. So it will be good if we have some growth charts handy. And this module will be very important, and it will solve a lot of issues when we manage children coming to us. As Jhankhana ma'am said, it becomes very easy to interpret or maybe to diagnose a disease which has been going on with the use of growth chart and symptoms. So, when we discuss the first thing, why do we monitor growth of a child? So, the first thing is barometer of well being in a child. If we are plotting a growth chart, if the child is doing well, we know that the child is doing well, and it shows we can reassure the parents that this is good. It is important pillar of preventive care. It helps reassure normalcy, as I told. It helps identify growth disorders, nutritional disorders, and systemic diseases early. And we will see how. So, if the growth of the child is poor, why are we concerned? Why do we want to address this? Because it can be a sign of disease or disability. There can be some underlying disease which we are not able to pick up. And if we plot growth chart, we come to know if the BMI is coming down, if the weight is coming down, or if the child is crossing height by some few centiles coming down, then we know, yes, that something is going on and this is not right. So, timely diagnosis and a social stigma causing psychological stress. When we see, for example, when we talk about maybe obesity or we talk about short stature, we know that what amount of stress does the child goes through, and they have that complex. When they go to school, there is bullying. So, it also leads to psychological stress, even in parents, that my child is not growing well. So, that is why monitoring growth is very important. So, what do we need to measure? So, from 0 to 2 years of age, it is length, weight, and head circumference. Remember, even if the child can stand, till 2 years of age, it is length only and not height. Not standing, it is supine length from 0 to 2 years. So, we take length, weight, and head circumference. And the frequency when they come for vaccination visit, that's must. Okay. Now, 2 to 5 years of age, what do we measure again? Then it is height. After 2 years, standing height. So, height, weight, and head circumference every 6 months. After 5 years, height, weight, BMI. Also, to add, if the child is overweight or obese, we have to take the waist circumference also here. So, that is every 6 months till 9 years, and then annually thereafter. And the SMR staging, Tanner staging every year. We know that cases of precocious puberty have increased. So, looking at the puberty, what staging it is, that is also important, and it should be done yearly. Early, it should be done early if there are any complaints from the parents. So, let us see how do we measure height. First thing, we do not measure with the stickers which is apply on the wall. That's not right method. So, no stickers. Even this method is not very accurate. As we see this child, see here, this is a cross, because this is not a very accurate method. The very accurate method is with the use of stadiometer, and it is fixed against the wall, rigid. And how does the child stand? Look at this. The child has worn shoes, slippers. There should not be any shoes, any socks, any slippers. Even if there is a high ponytail, you have to remove it. And the child should look straight. And there has to be the Frankfurt plane, which is parallel to the floor. What is Frankfurt plane? From the eyes, this corner of the eye to the ear. So that should be the Frankfurt plane. So the child should not look up nor down. This Frankfurt plane should be parallel to the floor. The occiput, scapula, buttocks, and back of feet all should touch the back of the stadiometer. No footwear, and feet should be joined. This is how we take, and that is what picture we have shown here of how to ideally take height of the child. So we should have a stadiometer in our setup, and that is important that every pediatric setup should have a stadiometer. For weight, we know that we usually have digital weighing scales nowadays, and that is to be used. But how do we measure the head circumference? We talk about height, weight, and head circumference. Okay, so for head circumference, wrap a flexible, non-stretchable measuring tape around the widest part of the head. So just above the eyebrows, above the ears, and then it goes back at the prominent bump, occiput at the back, and that is the occipitofrontal circumference, that is the head circumference. We have to pull it snugly to compress the hair, and we record the largest measurement. So this is how we take the head circumference. And remember, that is also important to diagnose any neurological disorders early. So the head circumference should also be taken, and as well as it should be plotted on the growth chart. So when we talk about the measurement of height, up to 2 years, it is length. As I said, even if the child can stand, it is length and not the height. So supine, and it should be an infantometer should be used. Every setup should have an infantometer. I have shown here in the picture where one end is fixed, where there is head. Here there is head of the child. The child lies down. Here there are feet, and then this is movable. You move, and then once the child is taken, you look at what centimeter is the length of the child. So this is the length. After 2 years, it is height, it is standing. Okay, so that we take with the help of stadiometer. When I talk about good stadiometer, you have Herpinden's stadiometer, and the one of the best stadiometer are from Seca, which is advisable if you want to buy. Infantometer, you get these ones only, and they are good. But stadiometer, they need to be good and accurate. Okay, let's start with case one. Any PGs here for the interaction? Anybody?
APG, please respond.
How do you take the mid-parental height? Any PG? So this will also be interactive session. Any one of you can answer. Please unmute and answer. Please don't write in the chat box. Please unmute and answer. Any PG? How do you calculate the mid-parental height?
Just unmute yourself. It's good. It's an interactive session.
It will be father's height plus mother's height plus 13.5 in case of boys, minus 13.5 in case of girls, divided by 2.
Okay. So that is your target height or mid-parental height. So it's 13 only. So when we talk about a boy, it's fathers plus mother plus 13 divided by 2. When we talk about a girl, it's father plus mother minus 13. The whole thing what you get is divided by 2. Now, where do you plot it? How do you plot it?
At 18 years of age.
Very good. So that is the target height or the mid-parental height where you plot at 18 years of age. What is the range? Should there be, like here I have mentioned a mid-parental height of 155. We put a dot. But how do you know the range? What is the range?
6.5
Plus
above
minus.
and below.
Yes, plus or minus 6 you can take, 6 or 6.5, or plus or minus 6. So you put a dot and then you put a bracket plus 6 minus 6. You count the squares, small squares, and then you put a bracket. So whatever falls within those centiles, if the child is falling within those centiles, that is normal. So mid-parental height range and mid-parental height or the target height or the growth potential of the child which you come to know. So whenever you're evaluating a child for growth, parents' height is also very important. But remember, sometimes asking for the extended family members' height also becomes important. Maybe the parents are okay, but maybe one of the grandparent is very short. So, or maybe uncle is short, or maybe Masi is very short. So, asking for the extended family members' height also becomes important. But parents should always be there when you're evaluating a child with growth issues. So, PJs, you tell me there is a 10-year-old girl complained for not gaining height. Her height is 120, weight is 25, MPH 155. Is she really short? Do you have, everybody has growth chart? If you can answer, we can be quick so that I can cover a lot of things.
Yes. Height should be 130. And immediately it is 120.
Okay. So how did you say that the height should be 130? Please tell me.
For first 4 years, it is 100. And for 5 centimeter per year, 30.
you can look at the growth chart and also see.
Yes,
When I look
she
at
is
10
short.
years, when I see she is at the 10-year line, when I look at the growth chart, if I see at 10 years, the fourth line is for 50th centile. What does 50th centile mean? The fourth line in the growth chart, that means the average child. So when I talk about 10-year-old with the average child, the line of 50th centile falls at 137. So this child 120 means,
Short.
yes, definitely below the last line. This line is third centile. Anybody below this last line is short. Now look at the mid-parental height range. The child is below the mid-parental height range. Look at the percentile of this. From 1, 2, 3, 4. The MPH range is between these lines, the lower four lines. So child should be, when I talk about 10 years, child should be here. Last four lines, somewhere here. Right? But the child is out of the MPH range. So again, that is abnormal, correct? So will you say this child is short? Yes, definitely the child is short. So, what is the definition of short stature? Anybody?
Below 2 standard deviation.
Perfect.
Less than 3 standard deviation.
Less than two standard deviation is abnormal, but less than third centile. Third centile line. Yes. What else? I want more people also to answer. What else? What do you mean by short stature? So, the definition of short stature is height less than minus 2 standard deviation or less than third centile, height below 1.5 standard deviation of MPH or outside range. If you cannot calculate, outside this range, as we have seen, the child should grow between these lines, last four lines, but it is again below the MPH range. And the growth velocity is also very important. So less than 25th centile of growth velocity, I will show you the growth velocity curves also, and crossing two major centile. Now again, remember this is abnormal. If you have been following the child for a long time and you keep plotting the growth chart, and if you see the child was on 25th centile, now on 10th, now on 3rd, that's abnormal. Otherwise, all else, the child is on 75th centile, then 50th, then 25th. The child may look normal if they come for the first time, that the, oh no, child is on 25th centile, this is normal. But what you have been observing sequentially was child was on 75th, 50 and now 25. So crossing of major centile, two centiles is again abnormal. That is again short stature definition. The child needs evaluation. So here, definitely child was below third centile, definitely out of the mid parental height range. Look at this, we have drawn the lines, right? Now coming to case 2, we have a 9-year-old boy coming with complaint of not gaining height. So can anybody tell me, is the child okay? Is the child below third centile to define short stature? Yes or no? Is the child below third centile line? Anybody?
Yes.
Yes?
No, ma'am.
No, yes, the child is just above
No.
third, between third and 10th. Okay. Is the child outside MPH range?
No.
No.
No,
So is
no.
he short? What will you do?
We have to measure the growth velocity.
Very right. So you will follow up this child. Look at this child. He's just above third centile. For on the MPH range, he is on the lower side. You will not say, chal, nahi, nahi, ye normal hai. No, no, you don't have to come for follow. You keep under follow up. Observe. See what's happening. So how do you see the growth velocity of the child?
Growth in 6 years.
In?
Measure the height at the 6 months interval and then decide whether it's.
So ideal is 1 year, but minimum of 6 months is also okay. So that is how you measure growth velocity and plot it on the growth chart, on growth velocity chart that I'll show you, right? But see, anything less than 4 centimeter is abnormal. After 5 years of age, I'll show you the growth velocity. But after 5 years, simple thing is 4 or less than 4. Less than 4 is abnormal. If they grow every year, less than 4 centimeter is again abnormal. So here we ask the child to follow up and let us see what's happening. Because first two criteria does not satisfy him. That means he's not short. But We followed up this child and see this. When we saw the old height records, the child is falling off the centiles. When does it happen? When the velocity is not okay. After 5 years of age, when we talk about this 9-year-old child, every year he should grow 5 to 6 centimeter. And here he is not even growing that. The velocity is less. That is why he is falling off the centiles. So crossing the centiles and coming down. See, he was on the fourth line, then third, and now second, and then gradually first between third and 10th centile, which is abnormal. So when we calculated the growth velocity, it was very less. It was just 3 centimeter. So we plotted here 3 centimeter at 9 years of age, and look at this, what we saw. When we see the growth velocity curve, this is for boy. This is the 25th centile is normal. Anything below 25th centile is abnormal. So this child, the growth velocity is here, this red dot. So that definitely this is a case of short stature, because velocity is less and child is crossing the centiles and coming down. This is the importance of sequential growth monitoring plotting. So always remember that growth plotting is very important in each and every child to pick it up early. If this child comes for the first time, I would have probably said, no, this is normal. Kuch nahi karna hai, dekhte hai, we'll see for 6 months, we'll see the growth velocity and decide. But if I had this chart showing me that the child is crossing centiles and coming down, I would have straight away not wasted time and started investigating the child. So this is the beauty of using the growth charts regularly and plotting them. So before we start discussing about short stature or anything else, I just want to highlight this point, that what is the ICP module for growth? That is infant, child and puberty module. So what is it? Remember, there are intrauterine many growth factors affecting the growth of the baby, I mean fetus. And there are also maternal nutrition and lot of other things. But when the child is born, for the first 2 years, the major role is played by nutrition and thyroid hormones. After 2 years of age comes the role of growth hormone. But remember, thyroid has to be normal. And around puberty, it is growth hormone plus the sex steroids, which gives a good pubertal growth spurt. But again, thyroid has to be normal, thyroid hormones. Thyroid hormone plays a major role, but when we talk about growth hormone, it starts playing the role by after 2 years of age. Before that also, but you will see that the first 2 years most important is nutrition, and after 2 years it is growth hormone, and around puberty there is maximum growth spurt which happens, a very good growth spurt, and that is because of growth hormone plus sex steroids. So when we look at the growth hormone secretion, yes, growth hormone secretion keeps increasing, but look at the puberty. That is a very good amount of growth hormone secretion. And that is why, remember, if the child is referred late or worked up late during puberty or after puberty for short stature, for height concerns, remember, you have lost the opportunity to give that child a normal height, because there is a good amount of growth hormone secretion and pubertal spurt is gone. So that is why the importance of showing here is identify as early as possible, not during puberty or after puberty, to give them a good result, because then we lose that opportunity to give them a good outcome with the treatment. So why do we use growth charts? Growth charts are simple, they are inexpensive, and they offer a great diagnostic tool. So what are the 3 simple steps of understanding growth chart? Which charts do we use? So now I'll be running through some of the growth charts which we have. So which charts do we select? How do we plot them? And how do we interpret? We will learn that. So what growth charts do we use? From 0 to 5, we use WHO, and 5 to 18, IAP growth charts. Now, why do we use WHO growth chart? What are they? What information do they have? Anybody?
Weight, height, weight for age, height for age.
So on the front, when you see the WHO growth chart, I'll just show you here. This is for boy, blue color. Always remember, blue is for boy, pink is for girl. That is how we get the growth chart. So here we have weight, then we have head circumference, and then we have length or height. This is used from 0 to 5 years. Now, WHO growth charts were given in 2005. They are very old. But why are they? They are called growth standard. What is growth standard? And IAP growth chart were made in 2015. And IAP growth charts are called growth references. Now, what is growth standard and what is growth reference? When we talk about growth standard means WHO studied the children in the ideal condition. If they are okay, they are breastfed, a good environment. So in ideal condition, how should a child grow? That is what is given by WHO growth chart. So in an ideal condition, how should the child, what should be the child's growth? That is called the growth standard, and that is what we have in WHO growth charts. Okay, and remember, it was done in 6 countries and India was a part of it. So that is why this very well applies to our population. And behind the chart, you have weight for length or height to diagnose underweight, overweight, obese, normal. Okay. And this is again for girls, pink. And look at the information you have. You have name and date of birth. So date of birth should be exact when you plot the growth chart, because you have to be very exact with the number of months also. Okay, so you have to write name and date of birth every time you start using the growth chart. And now we have IAP growth chart. 2015 it was done, and they are called growth references. Now WHO is growth standard. This is growth reference. Means what? Means how is the child actually behaving? So it was done in India in many centers, and then this growth chart was constructed. It was done in 2015. Remember, growth chart also need to be revised maybe every 10 years, because there is a secular trend of changing patterns of growth, and there is changing socioeconomic status, better nutrition, better healthcare facilities. So that is why they also need to be changed. So here, if you see in the IAP growth charts, there is again on the corner, you need to write name and date of birth. That's mandatory in each and every child to write down. Father's height, mother's height, and what is the target height, that is MPH. Here we have weight and height. And behind we have BMI. So BMI can be done after 2 years of age, but for us, we have a chart from 5 years of age for BMI. And how do we calculate BMI? Weight by height square, kg by meter square. And remember, for adult, cutoff is 25 and 30 for overweight and obesity. But for Indians, it is 23 and 27. 23 for overweight, 27 for obesity, because we are believed to have more metabolic complications with lesser BMI. So that is why our cutoffs are different. So according to adult equivalent of 23 for overweight and 27 for obesity, the BMI charts have been designed, and we need to plot on the growth chart. Now remember, every child from 3 to 6 years, they have the lowest BMI. So that is why when you see after 6 years, the chart goes up, lines of the BMI. So most of the parents may come to you and say between 3 to 6 years, my child is not growing well, बहुत पतला है, बहुत पतलो छे, very thin, skinny. Tell them this is normal, but yes, you also have to identify if there is some organic or some pathology going on. But usually this happens, and after 6 years, it depends, 6, 7 years, it depends on the lifestyle, and then child puts on weight, lifestyle, food habits, everything. So this is the IAP growth chart, and we also have, this is for boy, and we have combined WH and IAP. But what happens here when you plot on this, the lines are very close enough. So for the younger age group, you cannot plot it very well. This is what happened in the combined growth chart. But maybe 3 years, 4 years, if you want to plot at this age, it becomes little easy, and you can also compare with the relation to the MPH. So these have been combined very well. And then we have new growth charts. These are very good. These are pediatrician friendly growth chart, because we know in the busy practice, we do not have time to calculate BMI, and we do not have time to calculate MPH. But these days we also have software. Most of them, they do not write it. They type it in their software in the computer and give the print, where the growth chart are plotted by themselves from the software. So you don't have to work hard. But if you are still writing or not using software and using growth charts, good. I still use growth chart. I plot it and give it to all the children, all the parents and patient. So what do we have here? Here in the corner, these corner, both the sides, we have weight for height. Like we had from 0 to 5, we have weight for height, so that we very well know whether the child is overweight or obese. We don't have to calculate BMI. So this becomes very easy. And if we do not have time to calculate the mid-parental height, we have a calculator here on the right. We take a scale, take father's height, mother's height. Here it is father's height, here it is mother height. You put a scale. If the father is, maybe the height is 161 and mother is 151, you put a scale like this. It intersects at the 10th centile. You put the line here at the 10th centile, and then this is the range, plus or minus 6. So this becomes very easy. You don't have to calculate. Again, you have BMI at the back. Sorry. Also, when we talk about BMI, we know that these days overweight and obesity is increasing too much in children. So IAP guidelines have come up on obesity in December 2023. Very good guidelines. You should definitely read it. But they also show class 2 and class 3 obesity. So even that has been given here because we see a lot of obese children these days. So it's not only about overweight or obese, but it's also about class 2 and class 3 obesity, the comorbidities, the metabolic complications, and then we decide whether to give medications or lifestyle modification. How do we screen? How do we treat? So this is also very important. Now, when we talk about obesity, we talk about BMI, right? Now we talk about waist circumference. How to take the waist circumference? Anybody, please tell me.
At the level of umbilicus and above the superior iliac crest on the both sides.
Okay, and how do you interpret?
Males more than 95, females more than 85.
But for children, it can be different as per age and gender. So that is why we have growth chart. So let me tell you, how do you measure? Waist circumference is measured horizontally. This is given in IAP obesity guidelines in December 2023, which was published. What I highlighted the slide before. Waist circumference is measured horizontally in a standing child just above the lateral border of the right ilium with a stretch resistant or non-stretchable tape at the end of normal expiration. Okay. So this is how you take the waist circumference. And remember, it is more than 90th centile. But again, for Indians, as we discussed for obesity, for us, it is 70th centile. Anything beyond 70th centile is abnormal for us. Why? Because Indians are believed to have more visceral fat, more central adiposity. And remember, even if you're not overweight or obese, but the waist circumference is beyond what has been told, then again you have high chances of developing metabolic complications. And that is important to understand, that now importance of waist circumference is also great. So it's not just about BMI or height, weight, it's also about the waist circumference, and that is what we also stress now. So now we were talking about BMI and waist circumference, but remember, gold standard, if I talk about it, is DEXA, to look at the fat. But we don't do it routinely. It's just BMI and waist circumference. Now, when we talk about short stature, definitely taking upper segment, lower segment ratio is also very, very important when you're evaluating a child with short stature. Now, we also have charts for them. Okay, so this is upper segment, lower segment chart ratio. Now, anybody can tell me, how do we measure upper segment, lower segment ratio?
It is the length from lower segment is from pubic symphysis to the foot.
Yes. Yes. So this is how we measure. The child is standing. We palpate the pubic symphysis upper border. We put a tape till the heel, till the bottom, till the feet ends, till the bottom. And then we measure, that is the lower segment. Then from the height, we minus lower segment. Whatever is we get is upper segment. So then we divide upper segment by lower segment and we take the ratio and then plot it on the growth chart. So this is how we plot upper segment to lower segment ratio. So what do we come to know when we talk about upper segment, lower segment ratio? To rule out disproportionate short stature, right? So if the spine is short, your upper segment will be short, right? If your limbs are short, the lower segment will be less. So that is how we come to know, we conclude regarding the disproportionate short stature, and that is how we diagnose whether it is proportional or disproportionate. So whenever you are dealing with a case of short stature, measuring upper segment to lower segment is important. If any one of you want all these growth charts, I have it in a PDF, all of them I can share with you. You can email me. Now, when we talk about growth velocity charts, as we discuss, upper segment, lower segment is important, but we also need to look at the growth velocity, and that is how we come to a conclusion of how is the child doing over a period of time. Now, anything less than 25th centile is abnormal. So we know that the first year it is 25, then 12.5, then it is around 7 to 9 centimeter. After 5 years, it is 5 to 6 centimeter per year. Anything less than 4 centimeter is abnormal after 5 years of age. But again, as we know in children, this is again as per the age and according to the gender, boy, girl, we have again different charts, and these are Indian charts only for growth velocity, and they can be used. They need to be used to look at the growth velocity. And why is these line? Why are these line up? Anybody? What are these lines? Why they go up like this and then come down? What is this?
Puberty.
Yes,
Puberty.
very right. This is a pubertal growth spurt, right? That is why. And if you see, look at the girls. When does the pubertal spurt come? See, it's around 10, 10 and a half. Here, look at this. 10, 11. And boys, it's late. It's around 13, 14. So why do we NPH, when we calculate NPH, why do we take it 13? Where does the number 13 come from? Fathers plus mothers plus 13 minus. Where does this number come from? Where does this number come from? 13. So it is believed that average difference of height between adult Indian male and female is around 13 centimeter. That is why we have come to this formula of 13. So why boys are little taller than girls? Because the puberty comes late. The pubertal growth spurt happens in the stage 3 or 4. In girls, it happens in the stage 2. And the growth spurt is also more in boys than girls. Like girls, if I tell you it's somewhere around maybe 6 to 9, boys maybe around 9 to 9, 10, 11 centimeters per year. During puberty, they grow this much. And the puberty lasts for 2 years. And then there is slowing. Okay. So 5 to 6 per year, per year, per year. And then when there is puberty, girls will grow around 7 to 9, maybe 6 to 9 centimeters or something. And boys grow more than that, 9 to 11 centimeters in a year for 2 years. And girls have early puberty, so early growth spurt, and then they stop growing. Boys delayed puberty, more growth spurt, and even in puberty, it is in stage 3 or 4 that you see the growth spurt and then it slows. So it has been seen that boys are taller and the average difference is 13. So that is how the 13 comes. Okay. So growth velocity better to take for 1 year, but at least over 6 months. When is it abnormal? Less than 25th centile, or when the child crosses 2 centiles, come down, and anything below 4 centimeter before puberty. During puberty, 4 is not acceptable. The growth spurt, I told you, the range is different. But after 5 years, as I told, 5 to 6 centimeter around, they should grow. Anything less than 4 is abnormal during those years. After puberty, obviously, the growth slows down. After menarche, maybe up to 1.5 to 2 years, girls will grow. After that, they don't grow much. We cannot expect much. So this is growth velocity, first year 25, then 12.5, third and fourth 7 to 9, fifth year onwards 4 to 6, and puberty 7 to 13, depending girl or boy. We also have special charts for Turner syndrome. So if you look here, this is the normal red lines, and the blue lines are for the Turner syndrome girls. So we also have charts like Down syndrome, Turner syndrome, different. Even for achondroplasia, we have growth charts. So what is achondroplasia? What type of short stature? Anybody?
Short limbs.
Short limb, rhizomelic limb shortening. Yes. Yes. So the lower segment will be shorter, smaller. Now, just a word on Fenton and intergrowth 21 charts. There is Fenton, modified Fenton, and Intergrowth 21. We prefer using Intergrowth 21 charts for preterm monitoring of their growth because it very well gels with WHO growth chart. So sequential monitoring then becomes easy. And once the child is full term, then in the preterm you use intergrowth chart, and then when you use WHO, it is corrected age up to 2 years that you plot accordingly. So as India was also a part of again intergrowth chart, and again intergrowth chart is a growth standard as we discussed for WHO. Again, intergrowth chart 20, intergrowth 21 charts are like WHO. They are growth standards. So it was studied in ideal condition that for this much gestational age of the baby, good environment, the intrauterine environment, then how should child ideally grow? And again, India was a part of it, and it very well gels with the WHO growth chart, and that is why using intergrowth 21 is better. Now, this is just the selection and what charts do we have. Now, how do we plot it? So whenever we plot, first remember name and exact date of birth should be there, because it just cannot be 3.5 years as parents say, 4 years, 3 years. No, you have to be very accurate. 3 year 2 months, 3 year 1 month, 3 year 8 months. That is how you have to calculate. That is why you need the date of birth. Just use it like a simple graph. Put a small dot, not the whole circle. The dot should be so small you should not cover 2 3 squares at a time. Here I have shown little big dot just to show you. Otherwise, it should be a small dot only, not a circle. Mid parental height at 18 years and plus or minus 6. So that put a range and you know how is the child doing. Is the child within the range or not? Like this, you have to put a range. Then you see whether the child is within the range or not, MPH range. And then how do you plot bone age? By a cross. So if the child's bone age here is around 10.5 years, this is my height. I go back on the same line and put a cross at 10.5. So this is how you plot the bone age. Okay. When I put a dot here for the height, I extend it back, and then bone age is 10.5 here, 10.5, and I extend this line back and I put a cross. This is a bone age. Now coming to very important thing, how do we calculate height age and weight age? What is the importance? Anybody? Anybody?
If height age is less than chronological age, then uh, and bone age, or there is it's pathological or it constitutional delay, we can assess from that.
Okay. What is height age? How do you know what is the height age? How do you see in the growth chart? And
From the point of the height, we will horizontally go at 50th centile,
correct. And then come
and
down.
then we come down.
Yes. So when I talk about height age, that means from this dot, I go back to 50th centile. Here, 50th centile is here. It's written here, 50th centile, fourth line. So when I go back on the 50th centile line, it touches the 50th centile line here. From there, I come down. I draw a line here. And wherever it comes, this is 9. So that means height age is 9 year. And when I talk about weight, see the weight is more above 50th centile. So I have to go in front to the 50th centile here. And then I come down. So weightage is 13, right? So height age is 9, weightage is 13. This can happen. So how do we see height age, weightage? Wherever the dot is, you have plotted the current height and weight on the growth chart. From there, you draw a horizontal line till 50th centile. Wherever it is, आगे या पीछे, wherever, front or back, you draw the horizontal line and then you come down from there perpendicular and see whatever it comes, that age, that is the height age, and wherever this weight comes, you go to 50th centile horizontally. Wherever it meets the 50th centile line, you come down, and that is your weightage. So this is how you calculate height and heightage and weightage, and I'll be showing you what is the importance. See, like this. For height, again. So this is the heightage and weightage. So here if you see the chronological, sorry for the, yeah, almost same. Chronological age is 10 years, but heightage came to be around 8 or 10 months, weightage 12.8 years. So what is the importance of bone age? Can anybody tell me? So we have to learn all these things: height, weight, MPH range, weightage, height age, and also the importance of bone age, because you also plotted with a cross. What is the importance of bone age? What will you order to see the bone age? What X-ray?
Left wrist X-ray to
Only wrist? What do you see in the wrist?
mm,
Number of carpal bones.
Yes. So this is what I wanted to highlight. We no longer use this method of calculating the carpal bones. It is very inaccurate and we do
we
not do
need
it. So,
epiphysis.
yes. So please stop doing that. For bone age, we take X-ray of the left hand. Do you do bone age in all the child? No. When you're evaluating for short stature, or maybe for a tall stature, when you suspect there is a precocious, yes, advanced bone age, when you suspect there is precocious puberty, that is when you again order it. So when you order a bone age, it's X-ray whole left hand, including the wrist and fingertips. Sometimes what happens when you order, they cut the fingertips. No, we need to calculate epiphysis. Now I'll show you. This is the Atlas of Grulich and Pyle, very old. They started working on this, but this is very old. We no longer use this Grulich and Pyle. What we currently use is Tanner Whitehouse method. You also get a bone age app. You can download it and start using it. Tanner Whitehouse, you calculate the 13 epiphyses. Look at these. All the epiphyses you have to put, how does it look, and it will calculate and tell you this is the bone age exact. So Tanner Whitehouse method is currently what we use. We also have other method, and we have bone expert app, which is very costly. It gives you result in few seconds, but Tanner Whitehouse method, it takes little while, around 5 to 10 minutes. So you should have that. Even if you practice a lot, even then it takes few minutes to come to a conclusion of what is the bone age. For experienced pediatric endocrinologists also, it takes a time. So it only comes with a habit. So Tanner Whitehouse method, but always order XL left hand with wrist, including the fingertips. So everything till here. And you calculate the 13 epiphyses and come to a conclusion. But why do we do bone age? To look, it is to complement the growth assessment. Whenever you're assessing growth, and when you find that the child is short or tall, advanced, that is how you do it. That is why you do it. It speaks of the growth potential of the child, and we can predict the adult height also with that. Even for normal children we don't use it, but if at times the child are very parents are very anxious and they come to us, we tell them that we have done a bone and this looks like this child will reach up to this adult height. We can also predict that. There are a lot of calculations we do, and then we come to a conclusion. So it's assist in evaluation child with short stature or tall stature, helps identify condition. If there's a delayed bone age, it happens in constitutional delay in growth and puberty, but you will find more delay in hypothyroidism and growth hormone. Constitutional delay in growth and puberty, it may be around 1 to 2 years. But when you talk about hypothyroidism or growth hormone deficiency, it will be beyond 2 3 years of delay in bone age, which you found. Advanced bone age in precocious puberty. So these are the disorders related to them. And sometimes from the X-ray, you will come to know whether there are any skeletal disorders which are affecting the growth. From the X-ray only, you can come to know that some skeletal disorder is going on. This bone shape is not okay, or this is not okay. It helps monitoring the effectiveness of therapy. So whenever the child is on therapy, we do bone age yearly, at times 6 monthly, but yearly when the child is on therapy. Maybe for precocious puberty or for short stature on growth hormone therapy, we need to do bone age assessment yearly. But the take home point here for bone age is never count the carpal bones. Choose the proper method. Now, I want you to plot this growth chart for both the girls. We have a 10-year-old 6-month girl with case 3s with not gaining height and weight. What complaints she has? Abdominal pain, poor appetite. She has diarrhea on and off. Polyuria, polydipsia, weight loss, no other history, has normal birth weight. Case 4, again 10 year 6 month with not gaining height since 1 to 2 year. She has lethargy, constipation since 3 to 4 months, no systemic complaint, and normal birth history. Please plot and tell me what is happening with both the children. We need to be quick. You have to plot at 10 years, 6 months, weight, height, calculate the MPH, put it on the line of 18 years, take the range plus or minus 6, see how is the child doing, what is the height, age, and weightage, and what conclusion do you come to? Anybody would like to answer? It's okay if you don't tell me MPH, but at least height, age, and weightage. Yes. Case 3, anyone?
Well, height is below third cent.
Okay, but what is the height, age, and what is the weightage? If any one of you are not sure how to do it, you can please ask me. I can explain it again. We are here to learn today, and by the end of session, you should be very confident on using growth chart and answering the questions on growth chart.
Height is 8 years in case 3.
Okay, and
And
age?
In case 3, height age is 7 year, 3 months.
10 years, 6 months, 126. Height age is what?
7 year, 3 months.
No, it's around 8 years. Okay. Okay, but tell me weightage. What is the weightage?
9 years, 3 months.
Huh?
9 year, 3 months.
No, 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 no. Weightage.
6.5.
6 year, 3 months. So, what is more affected?
Weight.
Or height age is 8 year, around 8 years, and weight age is around 6 year, 3 months. What is more affected?
Weight.
Weightage. And child has complaint of abdominal pain, not eating well, recurrent on and off diarrhea. So, what would you like to rule out? Some chronic systemic illness related to GI, which is going on, and that is why weight is affected, and because of some chronic illness, even the height is affected now. So, weight age is affected more than height age, and even the child has symptoms. So, look for some chronic systemic illness related to GI. Now, case 4, tell me. 10 years, 6 months, height is 121. What is the height age? Height age?
Someone answer?
9 year around.
No.
No. 7 year to 3 months.
Yes, perfect. 7 year, 3 months. What is the weight age? 10 year, 6 months pay, you have to go up to calculate weight, to put the dot on 29. Wait.
Weightage
Then,
is 9 year.
around 9.5 years. So, what is happening here? What is
Height is
more
more
affected?
Height age is more affected.
Height age. So, child height age is more affected. Weight seems to be okay. Not she is 10.5 and weight is around 9 year 3 months. Here, child has lethargy and constipation. What do you think?
hypothyroid.
Yes. So here, height age is more affected, and the child has lethargy, constipation. Weight doesn't seem to be more affected. That means there is nothing which is going on like a chronic illness or nutritional, but it is endocrine cause, right? So this is what is happening. And here, weight age is more affected than height age than chronological age. So chronological age is 10 years, 6 months, but height age is 8.2, weight age is 5.1. So here, and here in case 4, height age is the most affected, then weight age, then chronological, and this is the chronological age. So this is GI complaints with weight more affected than height. So this is, as I told, some chronic illness related to GI. This is a case of celiac disease. Any child, short stature, pallor, not improving its iron, poor appetite, abdominal complaint, you have to screen for celiac disease. And remember, for celiac, it is total IgA and anti-TTG IgA, not directly anti-TTG IgA. They may have IgA deficiency. So, total IgA, anti-TTG IgA. If they are IgA deficient, anti-TTG IgG. So, celiac disease screening is must. And when we talk about height age being more affected than weight age, then endocrine cause, you have to, here they had lethargy, constipation, poor appetite again. So, rule out hypothyroidism. So, this is the importance of height age and weight age. When weight is more affected, maybe nutritional cause or chronic systemic illness like malabsorption, celiac, chronic anemia, anything. Here, when height is more affected than weight, the endocrine cause needs to be ruled out. Fine?
Uh,
So you should go.
Excuse me, Zalak ma'am.
Yes.
Zalak ma'am. Somebody has asked to repeat that height age and weightage. How to
Okay.
calculate, Dr. Neeti. So I think you'll have to retake
Here?
it.
Okay. So we child is 10 years, 6 months. We plotted the height, we plotted the weight. From there, we went back horizontally to the 50th centile. Wherever it touched the line, we came down. So this is the height age of the child, and weight age means I plot 10 years, 6 months, whatever weight I plotted here, and then I go back to 50th centile, and from there I come down. That is the weight age. Now, whenever the weight is more affected than the height, means what will happen? Your weight age will be less. Like maybe what we saw in the case, 6 year weight age and height age is around 8 or 9 years. So that means weight is more affected than the height. Weight age is more. That is what we see. When we go back and to 50th center and come down, see weight age. It's less. And then this is the height age. So weight age is more affected than height age. That means it is that means it is some chronic systemic illness or nutritional cause. And here what's happening, see, here we plotted the scenario, whatever was given at 10 and 10 years, 6 months, height and weight we plotted. Then we went back to 50th centile, drew a line perpendicular. Here we went back to 50th centile, drew a line. Here see, height age is more affected rather than weight. So this is what happens with hypothyroid. They won't be thin. The weight may be okay, but height will be more affected. Weight will be less affected. So when height is more affected than the weight, that means height age is more affected than the weight age. Think of endocrine cause. And when weight age is more affected, think of nutritional or any chronic systemic illness. Does this make it clear? Am I clear now?
I suppose so, ma'am. Nobody's saying anything.
So now what do we I go little faster now because I have told you how to see height age, weight age, calculation, everything. Now, what things we need to ask when we take history? Duration of growth failure. Now, that is very important. From when did it start? So that we come to the sequence of events. Systemic complaints, as we told, any systemic abdominal complaints, poor appetite and diarrhea on and off, polyuria, polydipsia, renal tubular acidosis, diabetes insipidus, so you have to ask for that. Headache, visual symptoms, any any space occupying lesion, energy levels, lethargy, in hypothyroidism, cold intolerance, constipation in hypothyroidism, behavioral issues, history of any medication, long term steroid intake may lead to short stature, any CNS trauma, surgery, irradiation, maybe they had some tumor and then they have taken radiation, any surgery like craniopharyngioma and the child has been operated. Yes, there are chances of multiple pituitary hormone deficiency, any chronic disease or malignancy which has been treated again. What is the importance of birth weight, preterm and SGA? You need to follow up. Anybody can tell me what is catch up and catch down growth?
Catch-up
Anybody?
growth is when a
Yes.
preemie will catch up to his age similar at 2 years of age
Yes.
Weight and
Catch up
height
is
to
if the child is preterm or an SGA child or SGA child or a preterm child, what happens is they are below the centiles, right? And when they catch up is in their genetic potential. Okay, you cannot expect कि parents height short and then he catches up too much. Catches up means it is not always 50th centile pe normal weight the child will reach. No, it is according to the genetic potential. If the parents are short, if the parents are tall, as per the genetic potential, child should catch up. Height and weight both. So SGA or a preterm, they usually catch up by 2 years. Some SGAs take 3 to 4 years. So if they don't catch up by 4 years of age, the guideline is we need to evaluate and they may need growth hormone therapy. So this is important. So birth weight is very important when you take history, but you have to look for catch up. Now, what is catch down? Similarly, for LGA babies or maybe a baby born to a diabetic mother, they'll have more weight. They will catch down. So they will come down on the centiles. Then this is normal. This is not abnormal. As we discussed, crossing major centiles, 2 centiles and coming down is abnormal, but not here. From birth to 2 years, this can happen. So birth history is important. LGA child now crossing centiles and coming back to the genetic potential. Wherever the parent's height is, it comes down, and when you see that the height is now coming down to maybe 10th centile, 25th centile, that's normal. That is catch down growth. So this happens in the first 2 years. Catch down doesn't happen later on. Okay, so catch up, catch down, this is important, but some children may need some more time to catch up. So that is why we have put a cutoff of 4 years. Failure to catch up by 4 years, we have to evaluate and they may require growth hormone therapy. Breach, asphyxia, chances of pituitary being affected, hypoglycemia, maybe multiple pituitary hormone deficiency, jaundice, hypothyroidism, congenital jaundice, edema of hand and feet, that means pointing towards Turner syndrome. So don't forget the dietary history. In India, still remember nutrition and chronic systemic illness are still the major cause of poor growth. Social history, family history, consanguinity. How were the parents? Did the parent have pubertal spurt later in life and grew later? That is pointing to CDGP. Consanguinity, we know some disorders are common in consanguineous marriage. Examination, remember Tanner staging is very important. Um, Puberty, so SMR you have to do. Anthropometry, obviously, taking all the parameters, look
Ma'am,
for
you're
dis.
not audible.
Oh, is it?
No, 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 you're audible.
Okay, okay. So even after 9 years of age, every child should we have to take BP for each and every child coming to our clinic. Fundus examination if you suspect some other disorders, and especially related to our CNS. Systemic examination, spine examination is also very important. What else? We have to look for all these features which match, like growth hormone deficiency, hypothyroidism, Cushing's, Russell Silver, and Turner syndrome. So these are the patients who will have some or the other signs, clues, which we come to know, like typical hypothyroid face, the pallor, the edema, which you see. And they'll be very lethargic. So all that you see when you see a child with, they will be short and little overweight in hypothyroidism. When we talk about Cushing's, purple stripe, buffalo hump, high BP, all that is possible. Turner, I'll discuss later. Growth hormone deficiency, I'll come to it later. Now, let us see some case scenarios. When we talk about physiological short stature, it is CDGP and familial short stature. Two conditions we have: constitutional delay in growth and puberty, and familial short stature. And the other thing is pathological. Now, we have a 12-year-old girl here. I'll go little fast to show you all the case scenarios, how they behave. So this is 12-year-old girl with a weight of 24 kg, height of 130 centimeter. Father's height 155, mother's 150. Both are average. Look at the MPH. Father's plus mother's minus 13, only 146. So here when we talk about this, that the child was short, definitely less than third centile. But when we looked at the MPH is only less. Both the parents are short, 146. We plotted the MPH range. Child is within the MPH range. See. So this is a case of familial short stature. We also took height, age and weightage. Sorry, there is some issue with the plotting, but both were same, height, age, weightage. So this is a case of familial short stature. You can even follow up this child and see what's happening with the child. But here the child's height, though below third centile, was within the mid-parental height range. Now you also have to see that because a child is 12-year-old, there can be pubertal growth spurt also here. At 12 years, she may have menarche. At 12 year, if the height is 130 and she has menarche, remember after menarche, the child usually grows only 5 to 7 centimeter, maybe 10 centimeters also, but the growth potential becomes less. So it depends on the pubertal status also. I am not discussing puberty here. I am taking this as a pre-pubertal child, 12-year-old with this height below third centile, but within the mid-parental height range. Now, if I feel that parents are very short, there can be like here it is 150 and 155. 155 for a father is short. There can be some other problem in the father which was not picked up. That does not mean we tell the child this is what we routinely see, that anybody who is seeing the child, they tell them nahi nahi, your parents are short so you will be short. No, it may happen that the parents had some disorder which was not picked up, and that is why we need to assess this girl and see if we feel that the child is short. We need to find out the cause and familial short stature. If we predict that her adult height will be very less, we can give her growth hormone therapy after all the workup. So here it is familial short stature. This is how they behave, but you can also follow up her and see the growth velocity, which will be normal in a familial short stature. So after 6 months, the growth velocity, we followed her for 6 months. Height gain is 3.5 centimeter in 6 months. That means 1 year velocity is 7 centimeter, which is normal. So that is familial short stature. Now coming to case 2 of a boy, he's 13-year-old, height is 135, weight is 24. Parents' height is good, MPH is above, is proper, it's normal, above the third centile, not below. So parents are not short. Height age is 9 year, weight age is 7 year, 8 months. Sorry, don't look at the diagram. There is some issue with the plotting in the PPT. So now look at this, bone age is 11 year, right? So boy is 13-year-old, height, weight, but look at the bone age, it is delayed. So as we discussed, bone age can be mild, they can have mild delay in a case of constitutional delay in growth and puberty. Now let me just talk about constitutional growth, delay in growth and puberty. In CDGP, what happens is, child usually maybe after infancy or 2 years, 1 or 2 years, what happens, how does the growth of the child happens? They grow usually below third centile. They grow parallel to the line, just below the third centile they grow. They'll have delayed puberty, and that is why delayed pubertal growth spurt, but they usually catch up as per their target height, as per the mid-parental height. When you ask the history, there can be one of the parent may have history of CDGP. They'll tell that my mother told me તું પણ મોડો મોડો વૈધો તો તારી પણ હાઈટ 10મા પછી વધી હતી. So that can be a possibility. They'll tell that my height also grew. I grew after 10th or 9th grade. I started shaving in college. That means there was a history of father having CDGP, or maybe a mother had menarche in 10th or 11th grade, late. So that is a history of delayed puberty in one of the parent, and that is how the child is also behaving. Child also has CDGP. So only from the history, many a times we miss this opportunity. Sometimes oh बड़ा हो जाएगा, ठीक हो जाएगा, मोटो थसे बराबर થઈ જશે. No, it doesn't happen in each and every child. You have to find out whether this is really CDGP. You do all the workup, you do a bone age, which is 1 or 2 year delay. Again, beyond 2 years, very much delay. You have to allow hypothyroidism, growth hormone deficiency, everything. So CDGP typically behaves like this, but it is like a diagnosis of exclusion. You do all the reports, not going up to growth hormone deficiency reports, growth hormone stim test. You do general reports, follow up the child, ask for the history in the parents, and look at the growth velocity. So this is what typically happens. They grow below third centile and then they catch up and they grow up to the target height. Now here we have a 10-year-old girl whose height is 120, weight is 15. Father and mother height is given here. This is now nutritional short stature. Look at the weight. The weight age is only 3 or 6 months. As I discussed, when weight age is more affected than height age, it is a cause of nutritional short stature or maybe some chronic systemic illness. This shows the importance of plotting the weight age and height age in each and every child when you plot the growth chart. So this is what happens. I would like to like you to see the growth charts. When this is normal, okay, CDGP, look at this line, dark line, growing below third centile, delayed growth spurt, and they catch up and reach the MPH range. Genetic short stature, parents' height is only short. Below third centile, okay. They keep growing like that, and within the mid-parental height range, short like parents. But as I told you, if the adult predicted height, if you calculate and that comes very less, again that is treatable. Pathological short stature, they'll cross major centiles and go down this dark black line. So now from physiological to pathological short stature, what is the etiology? Nutritional, celiac disease, IBD, inflammatory bowel disease. Then syndromic, we know Turner, Noonan, Prader-Willi, they'll be short. Again, nutritional and chronic systemic illness are very common in India still. We need to rule out any chronic systemic illness. SGA baby at birth, skeletal dysplasia. Endocrine cause, remember, hypothyroidism, growth hormone deficiency, again hypopituitarism, Cushing syndrome, precocious puberty. Remember, precocious puberty are initially tall, but because they get puberty early, we see that the parents feel they are tall, but ultimately they'll be short if you do not treat. And pseudo-hypoparathyroidism. So these are the endocrine cause of pathological short stature. So when a patient comes to you with a short stature, what will you investigate? What is mandatory? Routine investigation. Rule out any chronic systemic illness. Anemia. CBC is important. CKD. Again, remember CKD, there will be poor growth. Okay. Growth hormone is indicated in such condition. That is why RFT, LFT. Any liver pathology, again. Calcium profile, rickets. ABG, maybe renal tubular acidosis or any other illness. Electrolytes, again for that. Urine routine, maybe UTI or some other things if you find out in urine examination like proteinuria and some disorder. So these are the mandatory investigation. If the child is syndromic or maybe syndromic then like Turner or Down, obviously you do a karyotype. But if you feel the child has skeletal dysplasia or disproportionate short stature, then again you have clinical exome or whole exome. When you're dealing a child with Prader-Willi syndrome, you have to do methylation study, MLPA. Now when we talk about special tests, like I told you, if there is anemia refractory to iron, child is not responding, you have to rule out celiac disease. One of the special tests. And then what you do, total IG, anti-TTG IG as we discussed. Endocrine test, obviously free T4, TSH, thyroid. Hypothyroid, you have to do T4 and TSH. Hyperthyroid, you do T3, T4, TSH. Cortisol 8 AM, only when thyroid and cortisol are normal, only then you can go ahead with growth hormone stim test. You have to remember that. IGF-1 and IGF-BP3, according to weight and height, you have to interpret. It's little difficult. But growth hormone stim test should be done after priming in a girl or boy who are above 9 and 10 years of age. Priming with estrogen and testosterone, boy and girl. So I'll just take 2-3 cases of pathological short stature and then we can wind up. 10-month-old girl, she's short since last 4 years. She has constipation, she's a dull child. Now look at the weight and look at the height. Okay, height age is more affected. See, minus 3.9 standard deviation. You can also calculate standard deviation. So from that also we'll come to know what is more affected. Here height is more affected than weight, right? Heart rate was only 60, bradycardia, puffy face, dry skin, prepubertal, no goiter. Bone age when we did it was 6.7. So 6.7 is very much delay of bone age. Anybody can guess what is happening? Diagnosis is easy from the symptoms and the growth chart.
Hypothyroidism.
Yes, perfect. Hypothyroidism. So
And
bone
how
age
to
is very
calculate
common.
ST?
Sorry. Standard
How to
deviation.
calculate?
We have apps. IAP growth chart app. growth chart plotter. I have shown images at the end. You can download those apps. You will get the standard deviation calculation only immediately. Once you enter height, weight, date of birth, you will get the calculation directly of standard deviation. It's very easy. You can do it that way. So when we investigated, look at this. You are right. It was hypothyroidism. It was acquired and it is autoimmune. Antibodies were high. That is Hashimoto's. Rest of the reports were normal. Obviously, there is hypothyroidism, so there will be anemia also. So levothyroxine was started, and this is how child is doing now. She is doing very well. Now this is a case too. He is 4-year-old intelligent. Parents have been complaining of short stature since 1 year of age. Birth weight was normal. Relatives were advised as usual. Haji bau var chhe. Child has many more years to grow. He'll grow normally. So this is what happens. They come to us very late. He is 4-year-old. Some people come to us. Some children come to us at 10, 11, 12 years after puberty. Height is only 74.9. 1 year of height age. At 1 year, child is 75 centimeters. Minus 6.7 standard deviation. And weight. Now, look at this. When height is so much below the third centile, always think of growth hormone deficiency when so much below the third centile. Okay, you have to once give a thought of growth hormone deficiency. So all the reports were done. Routine workup was normal. Now when routine workup comes normal, you cannot think of anything which is so much below the third centile, right? Bone age we did, very much delayed. Yes, this is pointing towards growth hormone deficiency. Cortisol was normal. Thyroid was also normal. It was normal. So now what test do you do for growth hormone deficiency?
Growth hormone
Stimulation.
Perfect. You do a stimulation test. This is a 4-year-old child, so no priming is required. Okay. IGF-1, now again, it depends on the child's nutrition also. If the child is very malnourished, cachexic, any liver disease, it can come low. And you will think it is growth hormone deficiency. Right? So IGF-1 should be, you should look at the child and then decide whether to do, how to interpret. But IGF-BP3 is better marker in children below 3 years of age. Okay, so we did a growth hormone stim test. How do we do? If the child is girl or boy more than 9 or 10 years of age, we do a priming. Girl with estrogen. Boys also can be done with estrogen, but you can give a testosterone also. There is the dose and how to do it has been mentioned. Here we did a clonidine stim test. Clonidine was baseline growth hormone has no value. Remember, doing only baseline GH levels. That nothing that is not at all of any value. So you take a baseline GH, give clonidine. The dose has been mentioned here, and then every 30 minutes you take a sample. If any one value, see, growth hormone is secreted in a pulsatile manner. If I take only one report, one sample, maybe that time it is at the lowest secretion because it is pulsatile in the secretion. It will secrete, go back, secrete and go back. So maybe when I take one single sample, it may be at the lowest level that time. So that is why doing single baseline has no value. You give a clone. Here we have given clonidine. Then you do 5 samples. If any one value is above 7, you are sorted. That means there is no GHD. Here everything is 0, 0. This was a growth hormone stim test which was done, and this is suggestive of growth hormone deficiency. We started growth hormone. Look at how beautifully the child is doing. He gained 12 centimeters in a year. Such beautiful. So growth hormone deficiency, there are many causes. It can be congenital or acquired. But you have to look for mid-facial hypoplasia, infantile face and infantile voice. They may have truncal obesity, small hands and feet. Look at the midline defects, micropenis, bifiduvula, cleft lip, palate. We have to look for that. And these are the FDA approved indication: growth hormone deficiency, Turner, SGA, idiopathic short stature, Prader-Willi syndrome, Noonan, and chronic renal disease. There are growth hormone which is available daily dose as well as weekly dose. When parents they come to us, they'll be very scared of hormone injection. They'll be like, no, 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 we don't want to give us. You have to counsel them. That is important. You get pen as well as injections, which you can take with the syringes. It has to be taken sub-Q, daily or weekly, both are available. But weekly is only for growth hormone deficiency. Daily is for all other FDA approved indications at present. Now, case 3, which will be the last case, 13-year-old girl with short stature and delayed puberty. Anybody? Spot diagnosis. 13-year delayed.
Turner.
Yes. Syndrome. What can you see from the picture?
Wide chest, wide space nipple.
Okay. What else?
Well,
Can you see those multiple nevi?
Yes.
Multiple nevi. See, black spots here. Multiple nevi. Now, it can be familial, one of the parent can also have, but Turner syndrome can have multiple nevi. Here, I just want to point out that Turner syndrome may or may not have all the phenotypical features. So, there can be mosaic Turner. The point of showing a Turner syndrome here is any girl with unexplained short stature where you are not able to find the cause, doing a karyotype is must. Okay. So what can they have? Broad forehead, low set ear, short neck, multiple nevi, shield shape, chest. What is this sign called? Short fourth metacarpal. Bonus question to PGs.
knuckle.
Sorry?
Absent.
Short fourth metacarpal. It is called positive Archibald sign.
Pseudohypoparathyroidism.
Pseudohypoparathyroidism, very good. And Turner syndrome. So positive Archibald sign. Short fourth metacarpal. How do you see? Ask them to make the fist like this. Put a scale from first and third, so third and last finger. You put a scale. If the fourth does not touch the scale, that is short fourth metacarpal. You do a X-ray, find short fourth metacarpal. It is called positive Archibald sign. It is seen in pseudohypoparathyroidism and Turner. Very good.
And what did you said about any girl with short stature suspicion of Turner?
With unexplained, you don't know unexplained cause of short stature. You are not able to find out what is the cause of short stature. You have to do karyotyping. Right? So in Turner syndrome, when do you start growth hormone therapy? As early as you see that the child is faltering in growth, you start. There is no age cutoff. You don't have to do growth hormone stim test in a case of Turner syndrome. And when do you induce puberty? After 12 years. And when you find that with growth hormone therapy, how is the child's height? And then you start the growth hormone therapy. A hormonal replacement therapy for puberty. Okay, I'll just show you this case. This was a short boy, short neck, broad chest, hands reaching new family history. Maternal aunt's son is short also. They also said that he's very short, my maternal aunt's uncle. Uh, when we went ahead, what we saw, upper segment, lower segment ratio was abnormal. So then, because the upper segment, lower segment ratio was abnormal, we suspected short trunk as per the upper segment, lower segment ratio. What we found when we did x-rays of we did a skeletal survey to see that there can be some skeletal dysplasia because this is a disproportionate short stature. We found that there was typical humping in the vertebral x-ray. And that is why there was also a family history with this humping found in the x-ray spine with disproportionate short stature. And that is why we did a routine workup also, which came out to be normal. And that is why we ordered a genetic test, and it turned out to be spondyloepiphyseal dysplasia tarda. So this is how you come to a diagnosis of disproportionate short stature, what is happening with the child. So this is the significance of upper segment to lower segment ratio, which I am highlighting with this case. So how do you evaluate short stature? Height, weight, important. Take BMI, that is also important. If you see that the BMI keeps falling every time, you know that there is some chronic systemic illness going on, right? So BMI is also important. If BMI keeps increasing, but not the height, that means there can be hypothyroidism. So BMI is also important. Waist circumference, when you are evaluating a child with overweight, obesity, very important. Height, age, weight, age, height score. Then plotting on growth chart, upper segment, lower segment ratio, bone age, MPH obviously, and SMR, that is a puberty. You have to look at the puberty due to staging. So how do you evaluate? Disproportionate short stature, short limbs, achondroplasia, short trunk, MPS. So these are the from disproportionate, you come to such a conclusion and then you order the test accordingly. Proportionate, we know physiological, familiar, or constitutional delay. Pathological, when weight age is more affected, think about chronic systemic illness, think about nutritional cause. If height age is more affected, then you have to think of endocrine cause. Thyroid, growth hormone stim test, do a karyotype if a girl and you're not able to find out the cause, or you have a phenotypical features uh, uh, favoring Turner's syndrome, and any dysmorphic, you have to rule out other genetic disorder, Downs, Turner's, dysmorphism. So when is it abnormal? You have to refer to a specialist. So height less than minus 3 standard deviation, it is pathological. You have to work up and find out the cause. So you require a workup. Disproportionate short stature, yes. Retardation of growth velocity and associated increase or decrease in BMI, as I just pointed now. Dysmorphism, other clinical features, and marked bone age delay. Okay. What are treatment options? If any chronic systemic illness, treat that illness. Nutrition, if malnourished, improve the nutrition. If CDGP, at times, not every time, we decide whether to induce puberty, whether to start testosterone, aromatase inhibitors are required or not. Not every child requires treatment. Yes, growth hormone deficiency or other FDA approved guidelines, FDA approved indications of GH, you give GH therapy daily or once weekly. If a precocious puberty, you have to give GnRH analogs for a better height outcome later on, right? Or you may also have to use growth hormone plus GnRH analogs. Both can be given in combination, but it depends on many things. What is a puberty? What is a parent's height? What is a child's current height? What stage of puberty? Everything. um Maybe 3-4 minutes more and we wind up. I wanted to show this chart. Now when we talk about obesity, we know that most of the children have 90%, more than 90%, it is exogenous nutritional. That means calorie imbalance. Maybe they eat more, they do not exercise, so that is a nutritional or exogenous obesity. And whenever we have exogenous or nutritional obesity, and when you plot it on the growth chart, weight will be more, height will also be more. Now, what I mean by more height means when you calculate the MPH range and when you put the child's height on the growth chart, it will be on the higher side of the MPH range. So, if the MPH range is in maybe second, third, fourth line, child's height will be on fourth or fifth line. Outside the MPH range, just above the MPH range. So, that is tall and obese. Sorry. So always remember exogenous obesity means they are tall in the sense in comparison to mid-parental height on the higher side as well as obese. When they are short and obese below the MPH range or below third centile and obese, always think of endocrine cause of obesity and short stature. Maybe Cushing's, maybe hypothyroid, right? One case of this precocious puberty. This was a
Can
7-year-old
you
girl. Sorry, we need to wind
can
up.
you explain the previous slide?
Yes. See, look at this. Here, what is happening is when I take the star, the child weight is increasing, getting obese, right? Look at the height. Child is getting shorter. So, obesity plus short stature. This is abnormal. So, this here you have to rule out endocrine cause. Maybe Cushing's, maybe hypothyroidism, even GHD. They may not be obese, but height will be very much affected. So this is the endocrine cause of short stature when they are short as well as obese. When I talk about the routine obesity which we see nowadays, exogenous obesity or nutritional, where they eat more, they don't exercise, it is because of poor lifestyle. Here what happens? Look at the circle. The weight is increasing, height is also on the higher side. Now, it may not happen that the height is always on the 90th or 97th centile. You have to assess in terms of the mid-parental height range. So, if the mid-parental height range, if the child, this is the mid-parental height range, if the child is on the top of the mid-parental height range, on the higher side. So, if the mid-parental height range, maybe it is second, third, and fourth line from 10th centile, 25th, 50th, if these three lines, child will be somewhere around 50th or maybe above that, 75th. Anywhere on the higher side of MPH range, above or beyond that. just on the higher side or maybe beyond the MPH range. That is what is meant by tall. Tall means not always beyond, maybe beyond the graph or beyond the last line 97 centile. No. Tall and obese means in the mid-parental height range. As we discussed, short stature means below the mid-parental height range. Here, tall means above the mid-parental height range or on the higher side of the MPH range. So that is nutritional cause. Okay. Did you get it?
Yes, ma'am.
Now here I am highlighting a case of precocious puberty where she's 7-year-old. Now remember, precocious puberty in girl is thelarchy before 8 complete years, um, menarche before 9.5. Now you can consider 9 also, but maybe 9.5. Boys, testicular volume increase 4 or more than 4 before 9 complete years. Delayed is 13 complete years, no thelarchy in girls. 15 complete years, no menarche. Boys, 14 complete years, no testicular enlargement, 4 or more than 4. So she's 7 and menarche, which is abnormal. Height is 142. Parents were very happy. Oh, she's doing very well since last 2 years. 1 year, the height spurt is very good and she's 140. She's tallest in the class. Is this normal? Does this mean she'll be of a very good height?
No, ma'am. Ultimate height will be short.
Yes. So now they'll feel that the child is tall, but ultimately she'll be short. She is menarche. Look at the parents' height. So good. The MPH was 160 plus or minus 6. She only grew up to 147 centimeters. She remained short, not even 5 feet. They were told, हाँ okay, it is okay regarding the age of menarche. ठीक है, अभी तो होता है ऐसा. Don't do anything. Don't give hormone injections. This is what we see in the routine practice also. Whenever don't give hormone, why do you want to stop? This is natural. No. Here it is 147. Some children, they don't even reach. They are 135 centimeter or 137, 30 centimeter. They don't even reach 140 centimeters. So precocious puberty, they'll be tall at present, but ultimately short stature if you don't treat them. And right treatment is necessary after menarche, yes. But at 7 year with menarche, if you treat appropriately, you can give her a good height outcome. Yes. So I'm winding up. Take home message. Regular monitoring of height and weight is the road to health for children. It's very important. Growth chart monitoring is essential. Please plot the growth chart. You can buy softwares. Try putting them in the software if you have very busy OPD practice. Growth velocity is important. Predict growth over time and factors influencing it. Systemic evaluation helps in identifying the cause. As I said, karyotyping is must in a girl with unexplained short stature. Any anemia refractory to iron with abdominal complaints, you have to rule out celiac disease. Familial short stature can be pathological. Maybe one of the parent had growth hormone deficiency or skeletal dysplasia, which was not picked up. That does not mean the child cannot be evaluated or given any treatment. Early referral, early timely intervention improves the outcome. Remember, any short and obese child, we have to rule out the endocrine cause. Thank you. I won't take spotters. Sorry to take too much of time.
No, ma'am. Thank you, ma'am. It was really nice. I think we can entertain 1 to 2 questions. And one question is from Dr. Mehul sir. What is the late age up to which growth hormone can be started?
Sorry,
I
what is
think
the?
late age. I think up to what age growth hormone can be started?
So it all depends on the bone age of the child. So we tell them that there is this myth ke 18 साल तक बच्चा बढ़ता है till 18 years there can be gain in height. No, that doesn't happen. So at bone age of 15 years, the height outcome from bone age of 15 to 18 it's very minimal. So till bone age of 15 years, you have some scope. We have to start growth hormone therapy as early as possible. In Prader-Willi syndrome, we start as early as 2 to 3 months of age. That is for a good muscle tone. That helps because they have hypotonia. Otherwise, for growth, yes, as we discussed, it plays a role after 2 years of age. But if you feel there is hypoglycemia because of the multiple pituitary hormone deficiency, you have replaced thyroxine, cortisol deficiency, you have given high zone. There is growth hormone deficiency and child has hypoglycemia. You can start growth hormone earlier. Before 2 years of age, if the height is very much stunted, yes, you can. But usually we start growth hormone therapy after 2 years. Now, latest, it depends on the child's chronological age, that is current age, what is the height, weight that time, what is the bone age, is there any puberty or not. But I feel maybe after 12 and a half years, if there is early puberty, after 12 and a half years, even GnRH analog doesn't work much to stop puberty and treat. And if I talk about growth hormone, after 15 years, it doesn't work at all. But if you feel that the pubertal growth spurt is still left, and if you want to start, maybe 12, 13 years is okay, but it won't give much result. So best time is to start maybe before puberty, even during puberty. If you feel puberty has started and child is short, you can still give them so that pubertal growth spurt becomes still better. But after puberty, no, not much. And after born age of 15 years, not at all. It won't give you any result.
Any other question? Anyone else want to ask any question?
एप्स के बारे में बतानी आपने. What were the apps?
Everybody's asking for apps.
Just a minute, I'll share again. I had that image. This is a Prader-Willi syndrome. Remember, any child hypotonia after birth unexplained. No asphyxia, no syndrome, like no asphyxia, and you cannot explain why is the child having hypotonia since birth, failure to thrive, not taking breast milk. You have to rule out Prader-Willi syndrome.
Hypotonia cause vitamin D deficiency.
ના વિટામિન ડી થી ના થાય હાઇપોટોનિયા એટલા નાના બચ્ચામાં. Okay, so this is IAP growth chart. When you put here boy, girl, age, date of birth, height, weight, head circumference, parents' height, you get everything. They will plot it for you. You will get, see, standard deviation also. You will get Z score, target height also. They will calculate BMI also. Everything gets calculated. So this, and some of them told me that this is now getting difficult to download. I even tried using this growth chart plotter, and that was also quite easy. You can try any of them, growth chart plotter or IAP growth chart. If you need any of the growth charts, I can email you all those which I have shown today. You can email me and I can share all the growth charts if anybody want the PDF of it. My email ID is Endocare for Kids, ENDOCARE, Endocare for Kids, FORKIDS @gmail.com. You can mail me at endocareforkids@gmail.com and I can send you all the growth charts which we had seen. I also have growth chart for testicular volume, for stretch penile length, any child coming to you for small penile length, micro pennies. I have all the charts with me, Indian charts as per the age. So if anybody wants, you can please email me. I can send you all the charts.
Thank you, ma'am. It was really nice. It was a superb session, I'll say, because it's an important topic. And it was, you spoke with so much of clarity that everything was just crystal clear. Thanks a lot for your time. And
Thank you for the opportunity.
You're most welcome. I'd like to thank Jhankhana ma'am. She stays always and she stays for long to help. She's always there for us. All the senior
She is
faculty
very senior
members
to
who are
me, but
present.
she is more of a dear friend than a senior.
Yes.
Thank you, ma'am. Thank you, everyone, for being there, for participating, all the delegates, all the students, all the participants, and everyone who remained present till 10:45 night. Thank you. Thanks a lot. Have a
I'll
very
just
nice
put
day.
the, sorry ma'am, I'll just put
It's
email
okay.
ID. Somebody has put, I'll just put it in the chat.
Okay.
Okay.
I've just put the email ID in the chat. One of you have written wrong. Please look at this email ID, Endocare for Kids. You can send all. charts.
Yeah, she saw it. Okay.
Okay. Good
So we'll
night.
close here for today. Thank you, ma'am. Thank you, everybody. Good night.
Good
Thank you
night.
so
Good
much.
night.
Good
Good
night.
night. Good
Good
night.
night.
Good night.